So, I've been tasked to do clinical consultation, and I've done this a few times in the past. And what I suggest is that I'm going to go through how I would approach a station, give you two stations that have turned up, and let two of you to practice it in real time. Please do feel free to ask any question at any time. I'll keep an eye on the chat, but I may not answer it straight away. Um, like I said, the aim of the session is to introduce the aim of what the clinical consultation is, because it's a relatively new station, what is expected of you as a candidate, how to sort of develop a strategy to score good marks on this, and to try and cover, some common presentations that come up in the stations. There are loads and loads of presentations that are coming up. And like I said, since it's a relatively new addition to PACES, um, the there are new stations being built in every year to the to PACES. So just because everyone needs to remember what the carousel looks like, I don't know when they would remove 23 out of it off the website, but we're talking about station 2 and station 5, which are the consultation stations. Um, so before this was termed as a station 5 clinical consultation where you had two sort of complex patients and you had 10 minutes each and you had to do a focus history exam and Viva with all in within 10 minutes. So obviously that wasn't a very well structured station because you sort of had to rush through it. And the patients you brought in had to be quite specific and had to be quite very, you know, neurofibromatosis, for example, something that you could spot diagnose almost. Um, the reason why I point this out is because a lot of resources still aren't new, so they will still refer to this clinical consultation as a station 5. Um, but now the clinical consultation, it's a 15-minute um, station for you to do a history, examine, and sort of respond to the patient questions. And I'll come on to why that's really important. Now, I've had a lot of people say, what is a suggested time? So I've just come up with a time sort of scale of what you should do in terms of history, examination, um, and explanation to patient. The problem with this is obviously because the presentations can be so different, and your exam findings can be so variable, this isn't exactly a perfect recipe for every single station. So there is a degree of flexibility. What I would say is that if you have not laid hands on the patient at 8 minutes, you do really need to get on with it because it takes a couple of minutes to do any sort of focused exam. And you also remember in this station, you can take a history whilst you examine. So you can do that just like you do in normal life. In A&E, you don't rigidly do a history and then examine. You sort of do a mixture of both. So, and if it's sort of fluid like that, um, you're not going to be docked any marks at all. The other key element of this is to explain a plan to a patient. And the plan has to be exactly like you would in A&E in terms of we're going to admit you, we're going to follow you up in STEC or ambulatory care, etc. So you have to do those things. And ICE, for people who don't know what the acronym stands for, is ideas, concerns, and expectations. At the end, you get sort of a 4 minutes viva with the examiner to try and see if you've scored good marks in the clinical judgment. So clinical consultations, you get scored on everything. I've moved on to the next slide to just give you an example of what a station would look like. So this is a PACES consultation station for the new format that's on the website, which you can search up freely. It tells you the details and it tells you it's usually a referral letter. Then the referral letter is usually either from the emergency department or GP, etc. And it will have a brief history and some observations of some sort. Some of them do have blood tests, and some of them do have scan reports, but those are vanishingly rare. The majority of them will just have observations and maybe some blood tests. So let's just look at this one. So you're the core medical trainee in the medical assessment unit. So they haven't yet changed to IMT yet on this one. It tells you what your task is, etc., and tells you the 15 minutes. The clinical referral is quite short, so the patient's had a blackout and has fully recovered. Routine blood tests are normal, so it's told you the full blood count and renal function are normal. And please advise regarding his diagnosis, and he's given you his observations below. So the key elements when you're outside the room and you've been given the referral and you've got your time to prepare for this station is number one, just think like a med reg because that's what they're just assessing you on. So just work out, remember where you are in the hospital. Are you in A&E? Are you in resus? Are you in ambulatory care? Are you on a ward? Just think about those sort of things because that's very helpful in terms of logistics if you need to move patients. Um, I think start thinking about what questions you're going to ask and what is your differential diagnosis. Okay, so a blackout, there's a list that you're going to ask or think about. People can put in the chat if they've got a way of remembering or how they would approach this in terms of what differential list they have. I think what's more important instead of generating a differential list though is with your differential list, work out what exam are you going to do and what bits of the exam. So you do not have to ever do a full exam of a thing just because you're going to do, oh, I need to listen to the heart, so I must do a full cardiac exam. No, you can just listen to the precordium if that's all you need to do. Um, so you can choose bits and pieces of exams that you need to cover in your station. So I would suggest in a blackout, you would probably want to do a bit of a cardiovascular exam and a bit of a neurological exam because the main differentials for a blackout are either cardiological or neurological. Try and think about what questions the patient will have for you. So I'm sure some of you may have done some of the communication stations. So you always have to cover the safety points, you know. So blackout, you've got to think about any sort of seizure, TIA, these sort of stations. You always have to think about the drive-in because that's always a big question. Okay, so the that's going to come up. So that's how I would think about and do what I would do in my preparation stage. I don't know if anyone's got any questions now. I can't see anything in the chat, so I'll carry on. So we talked a bit about this. I tend to be well when I was practicing this and doing consultation stations. For me, it helped me just writing down um, the the constructs of a history. I know that sounds silly and maybe you may not need to do this, but I just sometimes do that just to make sure that I've got a structure in my head. And for example, in here in family history, I would have specifically asked about is there any history of cardiomyopathy, for example, any history of sudden cardiac death, which I've not written down on this, but that's the sort of reason why I do this. I sort of write down what I think is useful in terms of my what exam I'm going to do. Um, and I've identified about the drive-in and also the need to inform the DVLA. So that's my preparation. So I'm going to show you what the other side has. Okay, it's just so what the actor or your patient has. So your patient and your actor has an agreed script. Okay, so they have an agreed sort of story that they say, which has sort of gone through an exam process, and I think that's useful to know. So this is copied and pasted essentially from what the patient actually says. So they've got, as you can see, they've got a script about they read a book, felt odd, a few seconds passed out, ended on the floor, maybe out for 3 minutes, and it's not the first time. Looked very pale. Um, when seen by the wife. Okay, so I've just summarized that. Don't worry, the whole session is recorded, so you can read through the whole thing, and this is online. Um, But what I'm trying to tell you is they actually have a lot of information to share. So this is all in their script. So they've got all of this. And if you ask them the right questions, they will tell you all of this. So they do have a big script, which you can explore. But you've got to be careful because you do need to move on to examining the patient within the 15 minutes and explaining your management plan. So these are the questions that they will ask you. So they've got 7 questions that they can ask you in that station. Okay. So just think about how much time you actually do need at the end, and also in the middle to sort of be able to answer all of these things. Okay. Um, I hope that's and in the Viva, the very classical questions that you'll be expected to ask is to summarize the key issues of the case. So, um, what the patient's agenda is, what's your agenda, etc. What is your management plan? And if you did not, they usually will just ask you to clarify whether a safety point if there was one. So, can you drive? In someone in epilepsy where you've started some anti-epileptics or you started a drug which could be teratogenic, they would ask you about what about pregnancy, what about contraception, etc. So there's always a safety point which I will ask you as a clarifying question at the end in the Viva if you've not addressed it, or just in case you weren't very clear. Any questions on that? So that's sort of the structure of how a station would run. So they have all of this script and all of these questions already prepared for you. So you just have to hit them as you go along the history. So no questions. I'm just going to tell you, I'm going to show you the mark scheme for this. Um, and what I want to emphasize is how the reason why these stations are so important is because it covers every single clinical skill. So if you um, sort of get borderlines or lose marks on this, it really does start to hit your overall score. Um, and you can see because of the way the station is structured, you're going the clinical judgment, for example. Um, this is one of the best stations to address that. Yes, you've got Viva in the end of your examination stations, but this is the best station to assess that. Physical signs, that's fine, and physical examination, that's in your other stations, that's okay. And differential diagnosis, well, you've done the preparation hopefully outside the room before you've come into the room. And the big points are in terms of you're managing your patient's concerns and clinical communication skills. So those are the big points here that are different compared to your examination stations. So getting a clinical consultation station right is really important. I think I've done a lot of talking, and I think it's time for someone to hopefully volunteer. And I will sort of saying, I sort of show you how it runs. So, obviously you can't examine me because I'm in front of a laptop. Oh, amazing! That's incredible. So we have a volunteer. Let me see if I can.
My exam is next week, so
Brilliant. So this is you're going to absolutely ace this.
hopefully. Second time around doing the exam, so.
So the way we're going to do this is that I'm going to give you 7 minutes to take a history essentially, and I will tell you the examination findings after that. And the reason why I'm going to give you 7 minutes is because, yeah, well, you'll see the station. So you get 7 minutes to take a history, and you can ask for any examination findings, and then we'll sort of dissect the case afterwards, if that's okay.
Yep.
So I'll give you a minute for you to read it, but I'll just read it for everyone else. So this is a referral from a GP. You're an IMT in the same day emergency department, so it's SDEC. Dear doctor, could you please see Laura, a 32-year-old woman with headache? Her blood pressure is 132/90 with a heart rate of 84 beats per minute. HB is 135, that's normal. White's count is 8.9, normal range. Sodium 138, potassium 4.4, urea 8.4, and the creatinine 102, all in the normal range. I'm going to let you have a minute to think about it, and whenever you're ready, you can start asking me questions. And everyone else, what I would like you to do is I would if you've got a notepad or anything, just make some scribbles on what sort of questions that you want to ask. Um, and how you'd approach the station if you were the candidate.
Okay, I'm ready.
You ready?
Yep.
Okay, time to start.
Hello, my name is Dr. Canavan. I'm one of the doctors here today. Can I get your name, please?
Yeah, I'm Laura Trott. I'm
Okay,
32.
and 32. Perfect. Okay. I understand you've been having a headache. Can you tell me a little bit more about that?
It's been going on for a while now. It's just all over my head. And it's it's just getting worse. I can't really do things. And yeah, I went to the GP and they referred me in. They were thinking that they might need a scan or something. I don't know.
Okay. Sorry, sounds like you've been through a lot. How long has a headache been going on for?
So probably months now. So in total, probably about 4 months. But
Okay.
it's like I said, it's been getting worse recently, and it's more like persistent. So it's just there all the time now.
Okay, it's constantly there.
Yeah.
Okay. Can you describe it to me? Is it sharp and stabbing or heavy and pulsating or
I think it's sort of it's definitely not it can be sharp at times, but it's just dull. It's just there all the time.
okay. And whereabouts in the head, the front, side, or everywhere?
It does feel like everywhere, but it's mainly sort of in the front. Just sort of behind like the eyes as well.
Okay. Would you say it's pulsating or not?
Not always, no. It's just I mean
Okay.
there's like I said, there's moments where it becomes quite sharp but no, not always.
Okay. And anything that brings it on that you can notice
Um
or makes it worse?
I mean bending over and coughing has made it worse.
Okay. All right. And how would you rate the pain on a scale of 1 to 10? 1 being no pain, 10 being severe.
I mean it's always a constantly 7 out of 10.
Okay. All right. Okay. And it's there all the time. Does it wake you up at night or
I can't sleep very well, anyway, because of it. But I'm not sure. I don't think it's waking me up all night. I'm not sleeping
okay.
well
All
though.
right. Okay. And just a few more questions. Any visual changes? Any blurring in vision or black spots in your vision?
No black spots in my vision. I do feel my vision's a bit worse than normal, but I don't think it's blurry. Like I
Okay.
can still see you.
A bit more worse than usual though.
Yeah, I think so. I think it's not as it was like a year ago.
Right. Okay. Okay. And you said have you been vomiting at all?
No, but I have been feeling sometimes a bit sick because of the pain.
Right. And you said bending over and coughing makes it worse.
Yeah, yeah. I mean,
Okay.
I recently had in fact, like I think it was just going around, and I think the headache was definitely worse when I was coughing.
Right. Okay. Okay. And you don't want to lie down in a quiet, dark room or anything like that? No,
No, I
doesn't
mean,
help.
I'm not sure lying down really helps, to be honest.
Okay. And any history of migraines?
No, I've not got any history of migraines.
Okay.
It's the first thing I thought it would be. But no, I don't
Okay.
have any history.
All right. And any other medical problems?
No, I've got no other medical problems.
No medications you take every day?
No,
No allergies or anything?
no,
Okay. I'm just going to ask you some questions top to toe. So we've talked about the headache. Um, you've no collapse episodes or anything like that?
no collapse, nothing. No,
And no chest pain, palpitations?
no,
And no shortness of breath or cough?
no, not anymore.
Not anymore. And no diarrhea or abdominal pain?
No, I mean to be honest, I feel a bit constipated, if anything.
Okay. And any tingling or numbness in your arms or legs?
No,
No. Okay. All right. Just moving on to any allergies.
no allergies.
And who lives at home with you?
I live by myself in a flat.
Okay. And are you working at the minute?
Yeah, I work as a teacher.
Okay. All right. And do you smoke every day or just on the weekends?
Um, very occasionally.
Okay. And do you drink alcohol every day?
No, I stopped drinking.
Okay. And when was that?
Um, a couple of as a sort of months. I mean, I didn't drink that much anyway, but I completely stopped because I think it just meant worse hangovers.
Okay. And would you say you would have just drank on the weekends or would you drink sometimes during the week as well?
Um, Probably just on the weekends.
Okay. So socially. Okay. And no illicit drugs or anything like that?
No,
Okay. All right. Anything that runs in the family? Any medical problems?
no. I mean, my mum had a thyroid problem. Um, Nothing else that I know of.
Okay. All right. And what were you kind of worried about, concerned today?
Just, I guess, it's just the ongoing nature of the headache. I just wondered if there was something there.
Okay, yeah, that's understandable. So what I'll do now is examine you, and then I'll tell you about the plan going forward once I've finished examining you. Is that okay?
Yeah.
Okay.
So
So what?
the summary of the exam findings are you notice a left-sided um, visual field defect on the temporal side.
So bitemporal hemianopia.
Yeah, yeah,
Okay. So I would have done a cranial nerve exam, and I would have done an upper limb neurological examination, and I got the patient to walk.
which are all unremarkable.
Okay. And once I'd got the bitemporal hemianopia, I would have asked any weight gain at all.
I think I have gained a bit of weight. Yeah.
Okay. And how have your periods been, regular or quite absent?
Oh, that's a good question. So I actually have not had a period this year.
Okay. And no chance you could be pregnant?
No, no,
Okay. And no skin changes, like stretchy skin you've noticed, like or stretch marks or anything? No.
no.
And have you noticed that you're snoring more at night? Or I guess you wouldn't know. Do you notice that the clothes are tighter and the rings are tighter on your fingers?
No to both.
Okay.
It's 7 minutes, but I'm gonna let you keep going.
Okay. Um, all right. Weight gain, periods. Um, and have you noticed your sex drive has gone down?
Yeah, it has actually. Um,
Okay.
yeah.
All right. Anything else I've not asked that you'd like to tell me?
I mean, nothing else I can think of.
Okay.
Um, yeah, I
All
mean,
right.
I've not had my periods for like you just made me think about that. I've not had any periods since the start of this year.
Right. Okay. Um, right. So, you came in, you were worried about your headache, which is very understandable, and you've had it for 4 months, and it seems to be quite persistent. Um, and with the findings I found on examination, and your symptoms of your gaining weight and the lack of periods, we need to rule out an endocrine cause, an excess hormone in your body, and that hormone could be released by a gland in your brain. So what we need to do, we need to admit you, and we need to do a CT scan of your brain. Then we might need to do an MRI scan of a certain part of your brain called the pituitary gland, and then we'll go from there. All right, and we'll get the endocrine team to see you as well. We'll need to do more blood tests to look at your hormones, your thyroid level, your sex hormones, your growth hormone, and you'll need to be in hospital.
Could this be serious?
It's not life threatening, and it's very treatable. And we see patients like this, um, and we get it under control. So it's definitely manageable.
How would treatment work?
So it depends. At the minute, we don't know your exact cause. We do think it's a hormone problem caused by a gland in the brain, but we're not sure what exact hormone. Um, but if it depends, so we would either give you medication or we could do um, surgery. But that's definitely down the line, and I don't want to give you too much information at the minute. So the once we get all the results back, we'll have a more of idea. But it would be medicines and or surgery.
Okay, brilliant. I'm going to shift to examiner mode. So what would you do with this patient?
So this patient has a 4-month history of severe headache, constant, and with raised intracranial pressure signs of coughing and worsening on bending forward. On examination, there was bitemporal hemianopia. On further questioning, there was evidence of weight gain and amenorrhea and loss of libido. Putting all this together, I believe this patient has got an endocrine um, issue with some sort of hormonal imbalance. Differentials would include acromegaly, caused by pituitary adenoma, or Cushing's disease, also causing bitemporal hemianopia from a pituitary adenoma. Um, and differentials again from bitemporal hemianopia would be craniopharyngioma. But my most likely differential would be of acromegaly um, and or Cushing's. Investigations I'd like to do would be full blood count renal function as already tested, and then I'd like to do prolactin level, growth hormone level, insulin like growth factor. I'd like to do LH and FSH, and I'd like to do an MRI of the pituitary, and probably first before that I would do a CT brain to check for any obvious space occupying lesion.
Would you admit this patient?
I would, yeah.
Okay. I'm going to end the station there because that's 12 minutes, and obviously in real life you would have had some time to examine. Brilliant. How did that feel? It's obviously a bit simulated.
I wasn't sure if I got the diagnosis right. I wasn't sure if it's acromegaly or Cushing's, and I think you need a definite, don't you? I wasn't sure.
Um,
Or maybe
yeah.
it's Cushing's.
Yeah, well, um, I'm just gonna. So I didn't write everything down. A few more questions. Um, so I'm curious to know what sort of differential list you had, but when you walked into the station, walked in inverted commas.
I was just trying to get my Socrates ready, pass my social concerns and plan. I actually didn't have a differential. That was probably my mistake.
I didn't give you enough time, so don't beat yourself up on
I
that
didn't give myself enough time. I did have time. I just didn't.
because you had about 30 seconds when you went in, which is you know, that's fine. So you obviously would have a differential list. I think young women headaches. So, interestingly, for migraines, this is just a general point. So migraines, there are two. I think there's a research paper. I can't remember where I read this, but childhood car sickness and do you get worse hangovers? Or there's, do you get yeah, do you get really bad hangovers? Are two signs for migraines that sort of distinguish migraines from something else. So just as a general rule, um, raised idiopathic intracranial hypertension or benign intracranial hypertension is a condition that could also do this, couldn't it? Because it's a young woman, etc., and it's been long standing. So that'd be on the list, won't it? Cluster headaches, but you would questions you would ask is it didn't seem like a cluster headache, but you would wonder about watery eyes and things like that. Is there any autoimmune sort of condition? So is it like scleritis or etc.? But again, there's nothing, no eye signs. So I'm just throwing out differentials that aren't the answer. Um, and then there's sort of space occupied lesions or tumors, right? And so because I'm being an endocrinologist, I had to put an endocrine condition in. So does anyone know, just this is throw out to the audience, the most common pituitary tumor in the general population? That's functioning, sorry.
Pituitary microadenoma.
Yeah, so what type? What subtype?
Prolactinoma.
Yeah, so prolactinoma is actually the most common. Um, and what I would probably do is I'll come on to what they do. So ignore that bit. Um, I think endocrine stations are really good for clinical consultation stations, which is probably why I get asked to do this webinar. Um, but the problem is they're actually quite vague. So headache could literally be the only symptom they come in with. Um, I think I was quite mean because I hid a symptom or sign until you asked for it, which would have been lactation. And it wouldn't be spontaneous lactation. It would be lactation like if I pressed or etc. So that's a very specific question. The way I would approach any endocrine station once you feel like it's one. So I think the biotemporal hemianopia was the clue, wasn't it? Um, and this is why I say if you feel like your history isn't really going anywhere, you'll just go get on to the exam and just examine the thing that you were going to examine anyway. And then you find a sign and go, oh, God, okay, well, now I got it. So that's what happened in your thing. Now, this is a very hard station because just for argument's sake, if you went on to the exam, just being able to put down bitemporal hemianopia and being able to process it quickly enough without someone else saying it's bitemporal hemianopia, if that makes sense, makes it a
It's
very
hard
tough
enough. Yeah.
station. It's a hard
Yeah.
station. So that's why it has to be in your differential list at the start, because otherwise, if you don't anticipate it, it won't hit you, as it were. Um, I think in the exam, the two likely scenarios are probably growth hormone excess or acromegaly because they tend to be quite stable signs, or prolactin just because it's the most common. I don't think Cushing's will turn up that often unless it's iatrogenic Cushing's, i.e., they've taken too much steroids, but it may turn up. And TSH, um, secondary hyperthyroidism, so TSH omas are super rare. It's a super rare thing. So Graves' disease, which is a primary thing, that's far more likely. And LHFSH is not a recognized condition, really. Okay. Um, so I would screen for other hormones in a sort of systematic way. So you just go through hormone by hormone, which is what you did. You focused on the ones where the questions are the easiest, which is ACTH and growth hormone. Um, so I've just listed a few signs. Headaches is also associated with growth hormone quite classically. Change in suicide, ring size, um, and weight gain, easy bruising, purple striae, so these skin stretch marks, and are they purple? The classical thing about Cushing's is it's about your face being pumped up. Deficiencies are super hard, I think. So if you got an excess of one hormone, you can have deficiencies in the other. And I think in general in endocrine, it's very vague. So tiredness is actually probably I've actually I've actually written it twice because that's literally I've written fatigue and tiredness twice. Essentially, it's synonymous because that's simply how vague it is in endocrine conditions. So I would just go through all of them, and the one we obviously don't have here is the answer, which is prolactin, which is headaches and lactation and visual field changes. Um, anyone this is just to throw it out there. So obviously you referred to endocrine. Cabergoline, what would you have to think about? I'm really sorry about the malignant hypertension thing. That's not correct. What would you worry about cabergoline? Anyone? Feel free to answer that question. You can put it in the chat as well if you want.
Is
Do
it
you
a
mean
dopamine agonist?
cardiac fibrosis?
Yeah, so lots of people are saying lung fibrosis and cardiac fibrosis. Yes, so you 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 order an echo and you can do a chest X-ray. It's a cumulative thing over many, many years. Um, Retroperitoneal fibrosis is not a major worry with cabergoline. Um, but what's the one thing that you actually warn patients in the state in the station or in life? Yeah,
I
good thought about Parkinsonism. It's not that commonly seen actually.
think it's valvular fibrosis. No, was it valvular fibrosis or
No, it's not fibrosis. It's not. That's not the answer I'm looking for. It's there, but it's not the answer I'm looking for.
nausea or a liver function test? No, sorry.
No,
No, no, no, no.
shall I tell you? I'm not sure
Yes,
anyone.
please. Yes, please.
Okay, so the answer is impulsivity. Okay, so cabergoline actually changes your mood. So what you have is a scenario where patients, this is quite scary. they do things that they never intend to do. It changes your mood, so and impulsivity. So your relationship to risk changes. Um, and it can be quite insidious. So you could, for example, start I'll give you an example. So you start buying things that you can't really afford. Um, I'm just going to give you a few examples of patients started buying business class plane tickets and just started traveling around the world. Um, he did actually have reason to travel, but he started buying business class instead of normal economy. Gambling is a really common one. Um, so you,
May,
and if you're in a job where risk taking is you
may
know,
I just
it's a
ask
problem.
something? May I
Yeah.
ask something? Wasn't it something to do with ropinirole or Parkinson drug?
Um, well, it's the same class of drug, isn't it? It's a dopamine agonist.
Oh
Um,
yeah, yeah.
yeah, so it's the same class of drug, but it sort of activates some of your reward centers. It's the theory behind the impulsivity. So you have to warn them about it, because it can change their mood and it can make people aggressive and do things that they don't necessarily mean to. So yeah, that's the counseling of it. I heard this as well as related in Parkinson's. It is the complete opposite of Parkinson's meds, though. Um, is it the complete opposite? Not sure I understand the question there. It's a different type of Parkinson. It's not the same type of agonism. Yeah.
There was
So would
one.
I have passed because of it? Because I didn't get the diagnosis, or what do you think would
So
happen?
so so remember, if you do not get the diagnosis, you do not fail. Okay, and that's really important to understand about PACEs because the mark scheme, if I go back in time, okay, is you it's a driving test. So you're being assessed on all those domains. Okay. So I have no concern with your clinical communication. Your physical examination, I'm sure you'll be fine. Identifying physical signs I can't assess, but um and differential diagnosis. So you lose a mark there. So there's always so you'll be borderlined. And you so remember in PACES, there's two examiners. And the likelihood is they probably are going to borderline you. Both of them are going to borderline you. Okay. Clinical judgment, absolutely fine because your plan was perfect because you still did the test that would get you the diagnosis. Yeah. So there's no, and you've managed the patient's concerns, no problem. Managing patient welfare, no problem. So overall, you're going to pass the station. Yeah.
Okay.
The the issue really is that it's to think about this as a driving test. So you want to make sure that every single station, you're not getting too many minors in the same section. Yeah.
Right.
The reason why most people fail paces, most people, is identifying physical signs and differential diagnosis. So these are the two categories that most people fail paces for.
Can I ask another question? It's not really. It's kind of about marking of paces. Some of my colleagues said that they passed paces like numerically, but then they didn't get overall that the broad sections. Like when you see your mark scheme, do you understand what I mean? Like the four domains.
You mean those domains I've just showed you there?
Yeah, I think it's like, but they got the overall pass mark in the whole exam, but then they didn't get like the maybe clinical judgment. You need to get a certain points in that and
Yeah,
all over.
that's
So,
exactly what I've said.
all
Yeah.
right, yeah,
Yeah, so that's exactly the point I'm making. So some people will pass they'll get the overall mark and it will be above 130, I think it is. Um, don't quote me. I think it's about 130, but you won't get these specific marks in each of these sections, and therefore you do not pass paces overall. Exactly like a driving test. So if you have too many minor faults in one of the section or one of these domains, even, you will not pass paces overall. Okay, and main reason for people not passing paces is that there's the minor faults in each section. So that's why I'd never want anyone to go out of stations they're thinking, oh gosh, that was a terrible station, because you do not actually even if you fail a station, you can pass overall,
oh,
and that's really important to say because you only lose a couple of marks.
okay,
Yeah.
thank you.
Any questions on the marking? Because I think that I don't know if that's valuable, but you I, I I would never want anyone to sort of do a station and then just completely just fixate on it and not move on. You have to move on. That's the most important thing with paces. Um, Transgenic. So yeah, you're not meant to use um Goergeline is not licensed in pregnancy. That's right. Um,
Had one more question.
yeah.
Can we use these medical terms when explaining to the patient CT scan, MRI, or is it like brain scan?
No, so that I think CT scan is fine. So I don't think that's jargon. So I don't think that's jargon. I think that's it's common words. Yeah. So I wouldn't worry about brain scan, for example, because I think that's not specific enough. Um, but yeah, no, but you're right to think to be very careful with your medical jargon.
Another question, sorry. I'm from Northern Ireland. We don't have SDEC in there. Like, would that abbreviation be spelled out for me in the
Yeah,
exam,
yeah. So
or
yeah, it would definitely will be spelled out. I think I did, didn't I? I hope I did. May have not done it.
Short day emergency service.
Same day emergency department.
Same day emergency
okay,
department.
thank you.
So all abbreviations are spelled out in the actual exam. Okay. If there aren't any questions, then we're going to move on to the next station. This is actually what I got in my exam. So anyone want to volunteer for this?
Yeah, you can go ahead.
Oh, there we are. Brilliant. So I might just give you a bit shorter time if that's all right.
Yeah, that's fine. Thank you.
So you just get
Sorry,
five.
my camera is not working. That's why I cannot.
No, no problem. So 5 minutes. Whenever you're ready. I'm just going to answer one question. Do you advise ICE before or after the physical exam? I would tend to do it. That's a good one. So I would depend on the station. I might do ideas before, and I do concerns and expectations after. So, for example, in there's the headache one. I might have done ideas and concerns before actually in this one, and maybe sort of expectations after. Um, just because that's the way I sort of would structure it. There's no right or wrong answer of that. You just have to cover it somewhere. Okay. Whenever you're ready.
Okay. Oh, hi. Am I correct that I'm speaking to Mr. Usman?
That's right, yes.
Hi, I am one of the doctors in the SDIC today, one of the IMTs here. Uh, can you just quickly tell me what brings you in here today?
Well, I normally don't have any health problems, but I don't know, I just feel quite shaky.
Okay. So if I want to dig deep, can you tell me what do you mean that you're feeling shaky? Is it like the whole body is having problem, or you're having tremors in the arms and legs like that only? And
I
since
think,
how long did it start?
I think my arms and legs are definitely the problem. My
Okay.
arms mainly.
Yeah.
I just feel a bit unsteady on my feet, but my arms are definitely the problem. I feel quite shaky. I can't even, I don't know, hold things anymore at times. Um, and it sort of comes and goes. So it's not always there. Um, and you asked me how long it was. Well,
Yes, yes.
I have had it before, but like I've never come to doctors.
Okay.
Um, but recent this sort of I don't know period was probably the last week, and I am really yeah I am really shaky. Yeah,
Okay. Just to ask you, since you said that you're having this for quite long actually, and over the last few days, this has gone worse. That's what I understand. Is that correct?
that's correct. Yeah.
Okay. Anybody in the family, just a quick question. Anybody in the family suffering from the same problem?
No, no one in the family does.
Okay. So, since how long are you actually having this? If you want to, if you can tell me,
On and off for maybe a year.
on and off. And now also you're having on and off. That means yeah, you do not have this persistently. It is coming on and off. Is there anything that makes it worse?
Don't really know. No.
Okay, sorry. Fine. Anything that increases it that you have? Oh, sorry, and gives you relief from that?
Guess when I'm really relaxed. So
Okay.
I sometimes, yeah. So if I'm with my friends, I think it does go.
Mm-hmm. Anytime you have seen that alcohol is giving, is decreasing the tremor? Anytime you have seen that?
Yeah, that's a good point actually, because usually when I'm with my friends, I do drink. So
Yeah.
yeah.
Sorry to ask you, but it's a bit, I have to dig a little bit deeper in this alcohol. What do you think? Is it like too much of alcohol, or how would you classify? Or
I
how
think
would
I
you,
just I think I just drink what my friends drink. So don't think it's
is it occasional, you believe?
um I do
Mm.
drink every day.
Every day. Okay.
Yeah.
Yeah, every day. So, how long have you been drinking? If you don't mind me asking this question, because it's all related to your, diagnosis, coming up with a plan and the management plan and all those things.
Yeah,
Yeah,
that's fine. Well, a couple of years. Uh,
couple of years. Yeah.
as in I've always drunk, but not in this fashion. So maybe a couple of years like the way I'm drinking.
Okay. So, do you think that you have the drinking pattern has increased gradually over the last couple of years?
I guess so. I mean, I don't think I'm dependent on alcohol, but
Yeah.
I do enjoy drinking a bit more nowadays. There's not much I, you know, do, you know.
Mm-hmm. So, if I, is it okay if I carry on with this alcohol, like how much you take?
Yeah, sure, you ask what you want.
Yeah. So, can you tell me like how many cans or how many pints do you take per day, every day?
Oh, let me see. So I have a can when I wake up, and I have maybe one in the afternoon, and I don't know, a couple of pints of beer.
Mm-hmm. Over the whole day, couple of pints of beer.
Yeah, I mean, sometimes it's a bit more. Uh,
Okay.
if
Any
I go
anything?
out on a Friday, there'd be a lot more, if I'm being honest. But yeah.
Okay. Yeah, thanks for being honest because we need this information. Yeah, had you ever been like a have you ever tried to, quit alcohol or anything? Or did you have any time when you forgot things where you kept, or what happened the previous day you drank so much? Did anything happen like that?
Well, I
If
mean that always happens to everyone when you just forget, what happened the last night. Um, but I, you asked me if I ever tried to quit. I mean, I've not actually drunk um for a couple of days just because got
mm-hmm.
family around, etc. So yeah. So I can go without alcohol.
Okay. Any particular reason that started this alcohol, use?
Well, I lost sort of lost my partner a couple of years ago.
Oh, sorry to hear that. Sorry to hear that. So, would you believe that? To me, it sounds like you might benefit from some, counseling sessions also, because that can help you.
Oh, I don't believe in that.
Oh,
Um,
sorry. It was just my suggestion, my idea. Sorry, I didn't mean to be judgmental. Anything else apart than alcohol, like smoking?
no, I don't. I smoke sometimes, but it's
Yeah.
yeah. I mean, it's not that often.
Okay. And any recreational drugs?
Oh no, I don't stay away from those.
Okay, good to know that. Anything like particular, any disease that any medicines that you take regularly?
Um, no, I don't take anything.
You don't take anything. Anytime had you been diagnosed with diabetes or hypertension, blood
No,
pressure?
nothing. Like I said, I
Nothing.
I don't
Yeah,
see the GP for anything.
yeah, you don't see the G. Because anytime did you have jaundice or anything?
I don't know what that is.
The yellowing of the sclera. Sorry about my medical jargon. Sorry.
I don't think so.
You never had that, right? Any weight loss, recent weight loss, or any
Uh,
bumps and bumps in the body?
I have been losing weight. No, I'm supposed. I'm going to give you 30 seconds, by the way.
Okay. Any black stools at all? Have you
No,
noticed?
no,
No. Oh, okay. And any problem with the vision?
no.
Okay. Okay, Usman. So I would now like to go ahead with your examination.
Tell me what you're examining. I'll tell you the findings.
Yeah.
Tell me what you're examining. I'll tell you the
Oh,
findings.
sorry. I would like to do a quick neurological assessment and thyroid assessment.
The thyroid
And
exam is unremarkable. New exam, he's got bilateral coarse tremor, some
yeah,
instance tremor.
abdomen,
Um, no, no, his liver's enlarged. No splenomegaly. No bruising.
and no signs of CLD.
No signs of CLD.
Okay, fine. Any cave ring in the eyes or anything?
No,
No, nothing. Fine. So Usman, is it okay if I ask you a few more questions?
sure.
Yeah. Sorry to, ask you about your personal things, but what do you think about your sexual drive? Is it okay, or do you find having problems with erections or anything like that?
Oh, don't really know. I guess there's no difference really.
Okay. Okay. Good to hear that. So, Osman, after talking to you and examining you, and I would like also to see your, how you walk, so your gait.
So he's got a slightly unsteady gait. Just but swaying, but normal strength in his lower limbs, etc. Hello?
Anything like the like cerebellar dysfunction or anything?
No,
So cerebellar, there are no cerebral signs of the patient.
no.
Only coarse tremor when the patients are stretching the hands, and there is hepatomegaly.
Yeah.
Yeah. So Usman, talking to you and going through, the blood reports that were given to me in the referral letter, uh, it might be possible. And of course, we need to run quite a few tests before we, get to the final point. It might be that that your tremors and might be related to some alcohol related tremors, which you have quite increased in over the last few years, you're saying? Yeah.
Yeah.
And so we need to do some imaging of your tummy, which we call ultrasound, to see the liver, because could find that you had a enlarged liver. And also I would like to run your thyroid profile. There is a gland in the neck from where the thyroid hormones are secreted. So that's one of the hormone. I need to see that one, whether it's normal or not. On top of that, I would also like to, do some further tests for your liver enzymes. Yeah, if that's
Okay.
okay. And of course, talking to you, I believe that you might really benefit from our, discussion with the alcohol team, because uh, as far as I could understand, you are actually, over drinking, which is quite above the threshold that a person should be doing.
I mean, is it dangerous? Because I
Actually,
hear stopping alcohol. So I'm actually worried that, stopping alcohol is the problem.
yeah. So what I would suggest is we do not suggest stopping alcohol abruptly, because that can go on with some withdrawal effects. Rather, cutting it down, and the best person to deal with that will be our alcohol liaison nurses and the team. Would you like to have a talk with them after I finish my consultation with
I
you? I can
mean,
refer to them.
if you think it's any good, but I mean, I don't think I can stop.
Yeah, fine. And do you drive at all?
No, I gave up driving. As
Okay,
in, I don't have a car anymore.
okay, fine.
I'm gonna
So
end it there.
any other concerns, Usman? Anything else?
No, I'm gonna stop you there.
Yeah, thank you.
I was trying to remember what other questions I had for this one. These are the patient's questions I came up with. So I think I would have asked you to summarize the case and what would your management plan be?
Yeah. In summary, when I saw Mr. Usman, 45 years old gentleman, he had some coarse tremors and a hepatomegaly, and he had definitely he was over drinking. So over drinking and the blood results showed a mild raised ALT, which I saw, and a mildly raised lactate. He didn't
What's
have,
your management plan?
sorry.
What's your management plan?
The management plan will be cessation of slowly cutting it down, referring to the alcohol user nurses, check the magnesium and potentially detox with Pabrinex.
Would the patient be admitted into hospital?
With if the patient, I will do an AWS score. If it is definitely higher, I need to admit the patient. But if it is not, then community detox can happen. But we
Okay.
need to refer to the alcohol user nurses to talk to them.
End of station.
Yeah.
Brilliant. How was that? That was
I don't know. I don't know what was the diagnosis and everything. Because,
so. So
yeah.
this is actually what I got in my PACES exam, and it was alcohol withdrawal as a diagnosis, which I thought was quite simple, and it was a bit confusing. So I went down the routes that exactly you did, which is you check if they've got benign essential tremor, family history, thyrotoxicosis, cerebellar tremor. So you try and work out the causes of tremor. It wasn't a Parkinsonian tremor, definitely. So you go through it and it was stuff. Someone in the group and the chat has just put down Wilson's, and that's a really clever diagnosis to put down. Um, I think I think you would mention it in your differential diagnosis, right?
Yes,
And
I
you're going
did
to do your
mention ZF-ring. Yeah, I re did mention that.
yes, exactly.
Fisher rings. I did mention that.
Yeah. So and what you would say is in your Viva aspect to it, you list it there because he's in the right category for it. So that's quite good. The only other thing, I mean, Wilson's um the neurological findings are far more profound, aren't they? Just than just a bilateral tremor. And I was exactly so I was trying to plant some ideas of Wernicke's into there. So maybe starting to develop some Wernicke's. And the reason why I wanted to do that is to prompt the thought about this person probably needs to be admitted, number one, because they're probably actually withdrawing. Number two, they're going to need some IV Pavonix, aren't they? Or IV thiamine because there's a Pavonix shortage in the country.
Oh, I think I said Pebronix.
No, 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 no. This is just me just
Oh,
going through
oh,
the
okay.
case. Sorry, these aren't things that you missed. These are just things that you've to for everyone to just go through the case. In terms of before I forget, the only feedback I've got for you, Auntie, is if you I don't think you need to be as polite as you are around alcohol. And the reason why I say that is because if you build it up as a thing, then people may respond in that fashion. So I think you just asked your questions just naturally. It's like just sort of an inquisitive, non-judgmental way, which you did. But instead of just saying, "Oh, I'm really sorry to ask you this," it's like forget that. Just say, "Okay, so you told me this. Next question, next question, next question, next question," and then you just carry on because then you may just make it like an what's the word? You just make it seem like it's a completely normal thing that every doctor would do. So you sort of de sort of I don't know. Um, yeah, I guess the try what I'm trying to say is you don't make it like you don't put it on a pedestal or like a secret questions that you're asking. You're just asking just general points. Brilliant. So I've just written this down. I think you actually sort of covered all of it. ALS stands for Alcohol Liaison Service. Um, sorry, I'm bad with acronyms. I don't know why I keep writing them down because I know they're not universal.
That's
Um,
why I always use the AWS alcohol withdrawal score. That's the easiest for me.
Yeah, so you can use either to be fair. Some sort of withdrawal protocol or a score. Weaning regimen. The bonus points or the thought that um so I didn't get full marks on the station. And one of them borderlined me. I still remember this because I didn't get all of the GI bleed. Like I didn't go through all of the decomp AOD thing because I think I was still so perplexed by the fact that they brought someone that just had alcohol withdrawal into Paces. It wasn't seem as a Paces station. Um, the point I'm going to make though is that this is more common because if we go back to the whole reason why we want clinical consultations in the station in the exam, is are you a medical registrar? Would you manage this patient well on the medical take? So the other things to think about is where is this patient? This patient is an SDEC. Well, if you're going to admit this patient based on your CBAR protocol, they're going to be moved into majors or something like that, or minors, whatever. Majors probably if they're actually withdrawing, aren't they? So you need a bit more intensive nursing care, because they could be at risk of seizures and stuff like that, later down the line, couldn't they? Um, and if there's any evidence of decomp A or D disease, sort of GI bleeds, or which you all went through, constipation, etc., you're going to say that you're going to do the care bundle, um, look for signs of infection, sepsis, and you would probably move them definitely to majors. And if they're really unwell, a bit further higher up, because liver patients tend to be quite unwell, don't they? So the idea of where this patient goes is also quite important. And then you will just say that you'll reel off a non-invasive liver screen. Um, Brilliant. So I'm just I'm going to move on and I'm going to summarize. But I don't know if you've got any questions, do put them in chat or you can unmute and ask me. I think these stations, one of the key things is preparation. So being outside the room and trying to make sure what you are going to do and you're trying to visualize or trying to anticipate things is the best way of doing really well in the station. So I think trying to prepare for the questions that you may be asked, um, is helpful, both by patient and examiner. Never have to do full examinations, and it's a mistake I see all the time when I did the courses and stuff. People doing full cardiovascular examinations, like doing collapse and pulse. You don't have to do that unless you really think this patient's got Marfan's and you're looking for aortic, regurgitation or something. I don't think you have to do that in every single focused cardio exam in the clinical consultation. Um, so you've got to be selective. Just because you don't, for example, I'm sure you guys aren't doing ward rounds, um, and doing collapse and pulses on everyone. Um, Remember, you're trying to be a medical reg, so the consultant is looking at you and saying, could the medical take work well with this person? So the concept of logistics of where the patient goes in the hospital, that's quite an elite sort of conversation to have. And finally, please do ask me any questions. Um, I'll leave that on, and I've just got to post
I,
the WhatsApp group thing.
I,
But sorry, yeah.
I will just ask the same question which she also asked, like, how would you rate me? Sorry, because I'm asking only because the exam is very nearby. That's why. Sorry.
Again, you have passed, um you have passed that station, no problems at all. You have, and if just give me 2 seconds, because I'm just gonna put down the chat, but you will have passed that station with no problems whatsoever. Um, what you have to understand is paces, because it's not a tick box exercise, is it? I'm sure you've seen it now. That mark scheme is not a tick box exercise, it's a global assessment. Um, and they're not there's only a few red lines in paces mark schemes, which is if you don't list the differential diagnosis there, then that's a problem. But both of you did actually to do it, and I sort of said for you, Leonard, if it was you didn't explicitly say prolactin, so maybe a harsh examiner out there would go, "Ooh, borderline," but actually because of the rest of the thing of your consultation was really good and really sort of considerate and etc., then y y people just, I've marked paces, so people just, if once you're good in one domain, you just get good in the others. Um, so you both would have passed, and I've got no concern about that. Obviously, the benefits that you will have in the real exam is that you will have more time to prepare for the station outside. And I can't emphasize how important that bit time is to really just work out what your differential diagnosis is, because that's going to be a Viva question, really. Yeah. So being able to think through that and say, well, the causes of this include this, this, and this, and this, and these are the reasons why I think it's this rather than this, etc. And that's a really easy thing that you can prepare for. So yeah, any other questions at all from anyone else? Open the chat again in case. I've just posted the link to the WhatsApp group on there, so please do feel free to join. And here's again links to the courses. I've just put the webinar discount code. If you do have any questions, you can message me I'm on the WhatsApp group. I'm the person that asks for volunteers. And I'm sure all of you will do really well in your exam. So good luck, because it's I understand, I mean, it's the 9th of October, so a lot of you might be on your final sort of bits and pieces of getting there. It's a horrible exam, but once you're done with it, you never have to think about it again.
Thank you. Thank you.
I'll just hang around in case anyone had any questions. But thank you for joining.